All right, chapter 22. And we're going to have to break this one down, I guess, smaller because the last one was too long. All right, traumatic brain and head injuries. Now, you're going to see this one a lot because we live in Tennessee and there's a lot of football. All right, so I could see this in sports injuries. I can see this in car wrecks. I can see this in domestic abuse. I just have to, I can see this in shaking baby. All right, I have to figure out what kind of traumatic brain injury it is. First off, look at your concussion. It says that the minor head injury may cause concussion. A concussion is a term used to describe a closed head injury in which there is a brief disruption in the level of consciousness. So if I've got somebody that's been playing football, comes in, I don't see anything open. I might see a little scrape or something, but I'm not looking at this big open area. I don't see any of that, but they said, I blacked out for a second. I got this headache, kind of nauseated. I'm probably looking at a concussion, and that's usually the typical one I'm going to see. So when you're looking over and it says an open injury is there is a laceration of the scalp and a fracture of the skull with damage to brain tissue. A closed head injury is one in which the scalp and skull remain intact, but the underlying brain tissue is damaged. All right, so when I'm looking at an open injury, sometimes that's, I don't know. Sometimes it could be a little bit better, and that sounds weird because if I've got an open head injury, that's a bad one. Okay, so I'm looking at skull is open, and I probably have maybe some tissue down in there that's exposed. That's not good. No, it's not. If I've got exposed any of that, what am I at risk for? Huge infection, absolutely. But if I have a closed head injury and it's the same and I've got all that tissue underneath here that's disrupted, but my skull is closed, okay, what happens when I have any tissue that gets irritated? Yeah, it swells up, okay? I have that inflammatory response. At least with an open head injury, I've got room for things to swell, okay? With a closed head injury, I don't. Things try to swell, and there's nowhere for it to swell to, and I get pushing, I get lots of pressure on the brain itself. So, neither one are good, all right? You have to stop and think, though. If it's closed, automatically I'm going to have inflammation because anytime I have any sort of tissue damage, I'm going to inflame. And I have to have somewhere for that swelling to go. All right, so think about that. Definitely pay attention to your coop and contracoop. All right, if I've got a back and forth, then I've probably got contracoop, and that's your shaking babies a lot of time too. Okay, that's just however my brain sloshes and hits my skull. Wherever it hits at, it's going to determine which is what. Your big ones over here too, your subdural hematoma. It's a common result of head injury. It often happens in older adults as a result of a fall. An anticoagulant therapy puts a patient in greater risk. I'm always going to be at huge risk if I'm on anticoagulant because I can't clot appropriately. I'm just going to bleed and bleed and bleed and bleed. Let's see here. Really pay attention to that subdural hematoma because you're going to see that a lot. I've had patients pass away from subdural hematomas. And at the bottom, there's pictures of a subdural, an epidural, and an intracerebral. You can, if you'll just stop and think about what each one of those words are, you'll know exactly where it's at, okay? Think about where your dura is. The dura is what covers your meninges up your spinal cord and covers your brain, okay? So if I had a subdural hematoma, then I would have a hematoma or a collection of blood right underneath the dura, okay? If I had an epidural, epi means above, all right? And if I have an intracerebral, intra means inside. So that means I have a bleed inside my cerebrum, okay? So when you stop and think about the words, you'll have it. Signs and symptoms on the next page. Let's see what these are signs and symptoms of. Oh, brain damage, all right. Really pay attention to battle sign. Pay attention to your halo sign where I can put, if I've had hit my head and I've got something dripping out of my nose, it's probably not mucus. All right, so you can do a halo sign to see if that's cerebrospinal fluid. A battle sign is the bruising behind the ear. That's not a good thing. Not a good thing at all. So make sure you're looking at that, okay? Look at your nuchal rigidity, which is a stiff neck after one. That's a big, huge sign. Autourea and rhinorrhea are terms to know, okay? That's definitely if I've got fluid coming out of my ear. That's not good. That's not good at all. All right, so pay attention to those. Your LOC again is on box 22-1. That's a big one. When it comes to diagnoses of brain injury, you're going to see things like CAT scans and MRIs always. Make sure you know the terms contralateral and ipsilateral. Okay. Let's see. All right. So, the next page is an important one too. To me, it's always important. Okay? It's because it's talking about surgical interventions for brain trauma. All right? And that's going to be important because you're the one that's going to have them. Preoperative is already, it's important, but post-operative is a lot more important for the nurse when it comes to, because you're left with the patient. You're the one that's got to make sure you're doing the neuro checks, you're doing the vital signs, you're looking for complications from surgery, and there could be quite a bit when it comes to neurosurgery. All right, so you really want to look at positioning. All right, if I've had brain surgery, I'm probably not going to lie you flat. That puts too much pressure. Keeping the neck midline and preventing excessive hip flexion, that's going to help me. I'm eventually going to have to get up. I have to worry about these people laying in the bed. They're not getting up as quick as my other video. Say hi.
Who's talking?
I'm making sure that these people, because they're going to be stuck in bed for a little while, that when I can get them up, that they're going to be able to get up and move. Let's see here. Using nasal suctioning only if there is a written order. I really have to be careful. I mean, sometimes they go through the nose. When it comes to nose, the main thing that I'm looking for is drainage. Okay, drainage, clear drainage from the nose and the ears, which would be representative of cerebrospinal fluid. And that's your next bullet point. Providing a quiet, non-stimulating environment. They're probably going to have a pretty rip-roaring headache. So, I mean, and I'll have to monitor that too if my headaches get worse and worse and worse. I expect to have headache, but not one that continues to get worse. Administering only those treatments, comfort measures, and medications for which there's a specific written order. I don't think there's any reason why anybody would give medications they don't have an order for. And reporting promptly any changes in the neurological status of the patient. That means you're going to be doing all kinds of neuro checks and vital signs, and it depends on where you work, what kind of neuro check, and it depends on what the patient's had done, what kind of neuro check. If I've had major brain surgery, I'm probably doing just about every neuro check there is, which would be watching those pupils, looking for the drainage. I'm doing vital signs. I'm checking to make sure that when they put their arms out, they don't drift down. I'm doing the same with my legs to make sure that I've still got strength. I'm checking grips bilaterally. I'm having them push their feet down on my hands. Everything that I can think of that I could possibly put into a neuro check for these people, I'm probably going to do. I'm going to end this video here and pick it back up.